people are still joining on Zoom, but for the sake of time, I'm very pleased to introduce Dr. Bhatt today. Very happy he accepted our invitation to come here. Dr. Bhatt was one of the brightest fellows that graduated from our program. He's actually board certified in medicine and in neurology and in stroke. And he actually published at least 30 publications during his 3 years of residency. Very bright individual. I'm not just saying this because he's standing behind me. He truly is. He left us to go assume a directorship position stroke in Grand Rapids at Spectrum. And then actually he found his passion in Oregon. He went to Providence. He started a Tele-Neurology program. Now he's the medical director for a vibrant Teleneurology program that covers 102 hospitals. And he's here actually to give us some insight on the neurology, give us some input, how it's done, how we can actually use it to our advantage, and how it is the way of the future. So without further ado, please help me welcome Dr. Bhatt to the stage.
Thank you so much, Dr. Kasab, for the generous introduction. Okay, so I know we have a few of the faculty and the doctors and the nurse practitioners on Zoom. So my name is Archit Bhatt. Again, I was a fellow with Dr. Kasab, who is one of my mentors at Michigan State University, and then I transitioned to Grand Rapids and followed by to Oregon because my family's in on the West Coast. So I'm going to try to go through as many slides as possible. May not be able to go through all of them, but I'm going to try to go as much as possible. So I'm part of the Providence Telehealth team. Beyond that, I don't have any other disclosures. This is a slide Providence wants us to use. So the objectives of today's talk are, number one, recognize the key considerations recognize which are the key considerations for an inpatient teleneurology program. Number two would be like describe the barriers and hurdles to implementation and keys to success in executing and scaling a telestroke service specifically, and also teleneurology service in all practical matters. And the third would be recognize how teleneurology is evolving and how telehealth can support preparing for a hybrid neurological care. So this is not a telehealth, teleneurology volume. This is the overall telehealth volume for Providence. And so we started doing telehealth in 2012, Providence. It's a 51 hospital system-wide program. And if you can see, we had very few encounters in 2012. And since then, we have grown exponentially, doubled essentially every year through 2020. And our goal for 2020 was like 100,000 telehealth visits. These are all visits like neurology, cardiology, primary care, all the visits was 100,000. What we realized that after COVID, we had 1.7 million telehealth visits at Providence, approximating 70,000 visits per week. So we really got busy like all other hospitals in the country, where the dominant way of communicating with the patients was usually a telehealth visit wherever feasible. And that COVID, as everybody knows, it was the primary driver of adoption, telehealth adoption for the entire country. This is a snapshot of different telehealth programs at Providence. I'm going to get to teleneurology quickly, but if you look here, we have alternative visits, which are basically Zoom visits with doctors. Then you have COVID home monitoring visits, which is the second piece here, where how many patients were monitored. And if you can see the peaks and troughs, where with each COVID wave, there was increased demand in monitoring. We have a tele-sitter, tele-ICU program, which is pretty stable throughout the last 2 years. And of course, we have express care virtual visits, which is like the low-hanging fruit, sniffles and fever. And that has stabilized in January 2022, was increasingly utilized during the COVID times. We have a telepsych program, which is very busy, has two arms to it. One is the inpatient telepsychiatry, where the patients are in the hospital, and the behavioral health concierge, which is a direct-to-consumer counseling program started out for the providers and their families. And then we have the acute care division, which we are part of, the TeleNeurology and the telehospitalist group, which is slowly growing. So if you look at Providence, over the years, we have enabled more than 15,000 clinicians to use telemedicine, and we've had 4 million visits since January 2020. So we've been very busy deploying different telehealth infrastructures, and it's between acute care, monitoring, follow-up, and we've had more than 330 live sites for telemedicine and around 8 enterprise services. So we've divided the telemedicine portfolio into 2 broad groups. One is the enterprise level services like TeleNeurology and Telestroke, where a group of physicians provide services for all the hospitals. And of course, there are regional services where the individual groups would take care of their own patients using telemedicine. Sorry. So in general, like if you look at from a technology standpoint, we have on-demand urgent care, which requires a mobile app on the patient side. It's like basically 2 heads talking. Ambulatory virtual visits, again, the same scenario. We have remote monitoring, which has some peripherals and a command center. We have acute care telehealth, which has a cart with the camera, especially Telestroke, and some Bluetooth peripherals like stethoscopes, mostly used by the hospitalists, the medical hospitalists, because we have a big tele-hospitalist program as well. And the tele-ICU, which is mostly cart with the camera and a monitoring capability. Now we are expanding into hospital at home, which is run mostly by very experienced nurses and also supported by physicians, where you have not only all the peripherals in the command center, but we also have the mobile app on the other side too. So we have just requires basically low complexity medical admissions to be avoided by just taking care of them at home, like pneumonia, cellulitis, UTI. So let me pivot into neurology, where one of the challenges neurology has is twofold. One is very few neurologists are graduating every year, and it's basically, I would say, like 14 or 1500 neurologists graduate every year, and there are 5 or 6 specialties they branch out into. So it's going to be very hard for the hospitals in future to recruit neurologists for inpatient care. And if you look here on the right, this is the number of neurologists, 100,000. I don't know where the Tennessee, okay, right there, right here, it's like 4.3. So we are understaffed, like adequate staffing is probably like 6 or 7, but most of the country is understaffed with neurologists. And most of the neurologists are concentrated in the urban areas, and very, very few neurologists live in rural areas and serve their communities. So that's another issue with neurology staffing. And we do not have the same issue with cardiology and and emergency medicine. Like, for example, cardiology, it's like actually a subspecialty of internal medicine, and they have like at least 3,000 cardiologists graduate every year. So they have a lot more cardiologists graduate than neurologists. So this is the most important reason why the telestroke and teleneurology has developed, because it's not going to be enough docs to cover hospitals. So developing a teleneurology program is fairly simple, and it all depends on how busy and what's the vision for the institution. The first step is to just identify your customer, like who are your customers, like the patients, hospitals, the partners, the regional partners, regional hospitals, and the physicians. In my opinion, all of them. So you have to take care of patients, obviously, which is the center, the very reason why we are doing telemedicine, but also hospitals are usually paying for the service, regional partners are paying for the service, and physicians are actually physicians and providers. We have nurse practitioners too, who actually take care of the patient. So I would say all of them are important customers to take care of if you want to have a successful teleneurology program. The second step is to identify value chains and focus on quality and trusting relationships with your partners. So the two biggest value chains we have realized over the last 10 years is, number one is physician retention and patient retention. It's very hard to hire a physician. It's even harder to replace a physician. And we really feel that having economies of scale where you have providers scaling services across multiple hospitals is more valuable than hiring physicians and providers individually at each of these hospitals. It's just going to be more expensive. It's also important to identify what qualities you want in the physician. For example, most of our providers have experience with inpatient neurology. Some are stroke certified, some are neurocritical care certified, and again, data. So starting a teleneurology program, it's important to have at least some level of data, clinical data as well as operational data to start the service. And the third step is building out what exactly you want to do. The first thing is the product. That means, do you want to do a acute telestroke program, or you want to do just beyond telestroke, or you want to do a teleneurohospitalist program where you're doing actually follow-ups. Second is build your physician and provider NPP team, APP team. That's going to be very important based on how busy someone wants to be. It's very important to have the right mindset, the culture, and the providers to support that program. And third, I think Epic is a great way to do telemedicine if it's like one or two hospitals, but you almost want to have some sort of a platform to work when you're doing telemedicine in several hospitals, because you want to know how the patients are coming in, which patients to evaluate acutely, which patients to follow up the next day. Unfortunately, Epic is not the best way to triage patients. You can probably come up with a list in Epic and you can save and see the patients, but it's very hard to triage patients and respond acutely. And again, partnerships are going to be very important, and they are going to be dependent on, again, the cost, the quality, where what partners usually want is cost-effective, high-quality care. So those are the important 4 pillars for any teleneurology program. And I would say any Telehealth program, because this can be translatable to other telehealth services too. So there are three. Everybody sees teleneurology differently, but in what we have realized is that there are three big buckets of teleneurology, and these are very similar to what we do inpatient. Where you have the acute stroke bucket, which is the largest bucket. I would say most acute bucket. I would say, I don't know the largest. Then you have the emergent teleneurology bucket, where you have everything else stroke, like status or weakness, encephalopathy, where response is needed quickly. And the third is the follow-up non-emergent teleneurology bucket, where the patient's already admitted and they need a consult. The first two services, the acute stroke and acute teleneurology, are usually on demand, where someone's calling you and they want you to respond acutely and try to make an acute decision and then maybe follow up the next day. And the teleneuro hospitalist basically comprises of follow-ups of acute patients, but also sometimes non-acute cases where patients just have a headache for a few weeks and it's been in the hospital for a debilitating headache. And these patients sometimes are important. It's important. Some of these patients end up requiring neurology consults. And of course, teleneurology, you can also include teleneurology clinic, telestroke clinic, Tele-EEG, if you want to consider them for teleneurology. But Tele-EEG, obviously, it's just a separate group of epileptologists usually take care of the EEG service. Typically at our institution, there is a complex cycle of how a stroke or any tele service is operationalized. So the first thing that happens is, like, if there is a group of physicians or a physician interested in developing a tele service, there is an intake process. They have to fill out a very brief form. What do you want to do? What's the idea? And have just a basic idea why you want to do it and how you can help patients. And there is a billing, compliance, and a legal review for that proposal. There is a leadership review for business case, like what type of resources are needed, human resources versus technology resources to jumpstart that program. Once that is approved, there is a clinical operations get involved, and they say, hey, okay, this is how we're going to do it. We'll need a coordinator. We'll need a group of physicians. We need this technology. We contract with the technology vendor. We train everyone what they're supposed to do. We do the mock drill. Sometimes we pilot, and we launch the service. Now, not all the services which go through the pilot process become successful, but you will still have a lot of learnings from these pilots, and just makes it very easy to triage future requests. So we try to, at an enterprise level, we try to help as many groups and as many physicians to pilot their ideas, but not all of these ideas become like operational entities. So from a telehealth, telestroke program, so we've had this program for like 10 years now. It started out with 5 or 10 hospitals, and they were in different regions. If you know, like Providence is in 8 states, so we were in different regions, and then we kind of organically merged, and then we contracted partner sites. We have around 12 thrombectomy centers. Most of these thrombectomy centers during the daytime have been staffed by neurohospitalists. Some have night coverage too, but they do also have telestroke coverage. Most of the smaller centers don't have neurology, and we just cover them 24/7. We usually do acute codes around 10,000 every year. These are only the codes. Our average response time is less than 2 minutes, and our TPA rate is like 13%. It's pretty national standard, right? Between 10 to 15% based on where you are, your volume, and the distance from the hospital. You will have 10 to 15% rates. Most of our providers are either certified or have at least 5 years of experience working at a primary or a comprehensive stroke center. And some of, and I would say half of the providers are part of the Neuro Hospitalist group at one of the big centers, hospital. So these are the states. Our busiest obviously is Washington and followed by California, but I live in Oregon, so Oregon has pretty good volume, but we also have Alaska, Idaho, New Mexico, Texas, Montana. Arizona is no longer there. So, but these are the 8 states we have footprint. So measuring the quality is very important in a telestroke program because it fosters that feeling of trust with the partners. So we have clinical program managers in each of the regions. For example, they are essentially telestroke coordinators or stroke coordinators, but the title is clinical program managers. They not only have nurture the relationships with the sites, but they also partner with the physician leadership in setting up a telestroke conference. So we have a monthly telestroke conference. We discuss 2 cases every month, and the docs will present, and we provide CME for the docs. And these are very interesting cases because we usually have like around 150 TPAs every month. So it's very interesting, and how the different how the patients can go so complex, and sometimes how the decision making varies between physicians too. We have a peer review system where if it's an on-demand system as well as like a proactive system where we monitor especially the TPA and the thrombectomy cases, documentation quality, and that feeds into the quality committee, which is run by the physician leadership and the nursing leadership, the telestroke. So we have some dashboards. We look at physician quality metrics. So we have a physician dashboard, and we also have a site-facing dashboard, which they look at their metrics too. And again, the telestroke coordinators or the CPMs, they help collect as much data as possible. Some of the data is automatically collected in our portal, so they don't have to manually collect it. So this is an example of what the CPMs or the telestroke coordinators looking at every day. And this is the data which is collected by the access center. If you look at this circle here, I mean, these are the common workflow issues which we encounter where there is a failure to follow the workflow. The cart was not in the room, or there is an imaging delay, or handoff or communication issues, delay in treatment, or technology issues. Far and few between, but we still sometimes have technology issues. There is a documentation issue or a patient identification issue. So these things are collected by our access center, and they have a ticketing system which they feed it in if there is a problem real time, and they are basically followed up by the program managers the next day and resolved if they can. So this is a very important piece for operating a telestroke program if it's scaled to 100 sites. If you have a few sites, like 4 or 5 sites, you don't necessarily need to have. If you have a very efficient coordinator, you don't really need a sophisticated reporting system, but you definitely need a tracking system, like in a form, like an Excel sheet or somewhere where issues are tracked so that patient care is not delayed. So the physician dashboard, this is Dr. Atkinson, one of our neurologists. So physician dashboard this is a dashboard which is automatically emailed to the physicians every month. So for example, his average response time is less than 2 minutes. Activation to beam in time, that means once you're activated, how quickly you beam in with the robot. And you have portal compliance, that is, you have to fill out a short survey in the portal after you finish the consult to collect the data, and you have the note compliance where you did you finish the note in these patients or not. So these are the metrics which we collect for all docs, and we also send it out. This also improves trust with our partner sites, and also we use these metrics to have a 10% bonus every year for the docs. Most of our docs, I would say 100% of our docs qualify for the bonus, but this is something that keeps them on the toes. We also require them to attend at least 4 case conferences every year to be eligible for that bonus. So quality metrics are important because that keeps everybody grounded, make sure that they're responding quickly, beaming in quickly, writing notes properly, and attending case conferences. So this is a compliance score where our compliance was really low with the note compliance, especially with the phone notes. But then we added a compliance scoring report in 2019, and this is my score actually. So, and then everybody's compliance just jumped up to more than 95%. So we measure that in the portal, and we report that out to the doc. There's no punishment for having like 80% or 85%. We just want to make sure that the documentation is done properly. This is also a validated hemorrhage dashboard each doc gets. Get with the guidelines. One of the challenges with Get with the guidelines is that you can get an overall picture of how your group is doing. Hemorrhage like 2%, 3%, 1%. But what we felt was we don't have an accurate way of telling the doc, say, hey, this is your hemorrhage rate. So we have the Telestroke coordinator, only for the TPA cases, they collect hemorrhages. So yeah, this was a snapshot of 39 cases where it was 3%, but yes, it fluctuates from anywhere from 0% to 5%, depending on what month it is. So again, it's very important not only to know your door to needle times, but also what your hemorrhage rate is. That's because that's the other end of the spectrum. And we have some variability in docs, but most of the docs, I would say everyone is less than 6%. So this is a very important dashboard for when we are talking to like partner sites. Say, hey, what's your hemorrhage rate? It's just hard to know. And it's also sometimes hard to have a conversation with a doc whose hemorrhage rate is like 10%. So this is why we want physician, and this is also very confidential, and everybody just knows their own rate. That's it. We also, after each consult, we do a Telestroke physician satisfaction survey where the ED doc / the nurse has to fill a survey out. And again, the percentage of surveys we get back is around 40 to 50%. Not everyone fills it out. Everybody's busy. We understand that. But in the survey world, 40 to 50% is pretty good. So it's like how easy what is to get the consultation. Was the consultant return my call in a reasonable amount of time? I was satisfied with the outcomes? It's very simple, subjective questions about technology and the consultant, and each and every answer is rated from 0 to 5, I think. And I know some of you might have worked with this doc here, Dr. Sepkoda. He's with us now. He was here in Wrangler. So, but again, so we have this system which allows us to measure the perception of the ED docs, how they feel about us. It's very important because when they do real time, when they take the pains of filling the survey out, we are assuming they're doing the right thing and honestly evaluating our physicians. So again, I won't bore you with the details of Telestroke workflow, but it's important to have a vertical partnership in your system. Let's say, for example, you have 6 hospitals. All the hospitals should have a standardized workflow, how the robot it's going to get to the patient, how the nurse is going to interact with the doc, and uh, what's going to happen in the radiology suite. How is the CT, CTA going to happen? Who's going to read them, and what are the metrics of getting CT perfusion, so on and so forth. So it's very important to have alignment at a system level. We especially value that because we have 51 hospitals internally, so we don't want multiple protocols floating around. So we of course, hospitals can deviate from a protocol a little bit based on what their availability is, but we do encourage hospitals to have a unified protocol, at least on a broader level, to make sure that the physicians can work efficiently. And also, horizontal partnerships are important. Work with your external partners and and uh, and the hospitals where they may not have the right resources. Some hospitals don't have perfusion scans. So yes, we have to have a separate protocol for them. Or CT angiograms. It's very rare, but we do have a couple of hospitals who don't have perfusion CT angiograms. So we just have to come up with a little deviation from our protocol for them. We do use TNK and TPA protocols at several hospitals, and we let the hospitals decide what they want to use. We support both TPA and TNK. So we have a TNK protocol uploaded in our portal. So if somebody wants to review it real time, they can review it. So this was the example of a vertical partnership where all the hospitals adopted our TNK protocol and dosing. And of course, it has to go through the pharmacy committee, physician leadership, nursing leadership, and it took like maybe a year, but we were able to get this thing through it. So this busy slide is basically how our schedule works. Since we have so many hospitals, in the center of everything is the digital access center, where we have a 24/7 staffed center where a hospital can call an agent and say, hey, I want a neurologist for a stroke. And this is important because you don't want random pages appearing on your pager or phone. You really want somebody in between, like a transfer center or a digital access center, who can take those calls and then page out the doc. And these are the different shift types we do. We have around 3 docs during the daytime and like 2.5 docs at night, covering several hospitals. And the way it works is, let's say, for example, during the daytime, I'm on call and there are 2 other docs. So we get every 3rd call. And it's all cooked and baked into the system. If I don't respond, it's going to roll over to the next doc. The second doc doesn't respond, it rolls over to the 3rd doc. And the 3rd doc doesn't respond, it's going to roll over to all the docs. And all the docs will get a jump ball page where whoever is available can respond. And obviously they're not on shift, but they're just responding to that call, and they're going to get reimbursed for that call, responding to that call. So that's how we structure the backup during the daytime and also at night. Daytime, obviously, just by nature of stroke, is going to be 65% of the calls we get during the daytime and 30 to 35% of the calls at nighttime. Yeah, and this has, since this slide was made, is changed now. So you need the technology to change the shifts, because you add a few sites in a specific state, you end up having to reconfigure the call schedule. So it's very important to have as many docs as possible at as many places credentialed and licensed, and that's how the paging system will will figure out. The one good thing about the paging system is like we have so many hospitals. The paging system will only page the doc if they're credentialed at that site. So that's baked in that, hey, if I'm credentialed to 50 sites, I'm not going to get paged if I'm not credentialed at that site. So I can confidently respond to that page if I am, if I want to. The jump ball. So again, this is the business intelligence part where you really need a platform. If someone were to expand beyond a certain number of sites, I would say if somebody has a pretty busy volume, you really need some sort of a platform outside of Epic to communicate, so that if there are a few sites, 4 or 5 sites, the transfer center can probably handle it. But beyond that, you really need a platform where they can do the intake process. You can log into the portal and see which sites are, which cases are hot, which cases need attention. So this is another real-time data tool we use where we try to parse each and every case out based on the process, not based on only the door to needle time or the door to CT time, but the DAC here means the digital access center. So once you're activated, activation means once the DAC gets called, they page, I respond, I beam in means do a video consult, make a TPA decision, and then bolus is given and door to CT. So each and every process is parsed out based on their color coding. Let me show you quickly how it works. So this is obviously all providers, minutes median, and how activation is 5 minutes from the door. And then it takes 1 more minute for them to do paging. Of course, this is median, so it goes up and down. And then it takes 22 minutes from the door for me to respond, 38 minutes to make a decision. Sorry, 33 minutes to make a decision, 38 minutes to complete the CT, and of course, 40 minutes to give the bolus. So this is just a general idea where we really want to see what are the holdups at a telestroke level, because the rate limiting step beyond the CT scan at the telestroke level is when does the patient come back from the CT in front of the camera. So that is when I'm working in the hospital, I can just follow the patient. I can just go to the CT. I can give the bolus in the CT. That's great. But in the telestroke or teleneurology piece where you are waiting for the patient, so you're beaming in quickly, but if the patient's taking 20 minutes from the CT to back into the room, it's not something you have control over. Obviously, you're going to speak to the family, try to get more information in the meantime, but that's where the process needs to be ironclad, where especially in bigger centers, they exactly need to know how and where the TNK should be administered. We have a few hospitals which we do CT, TPA, and TNK. The robot is in there, and we just make a decision there. So these are our weekly volumes. If you see each and every, so this is more of an operational data where how these volumes fluctuate. Stroke is unpredictable. There is no way to staff for a busy night, and there is no way to staff for an easy night. There is no way. So you would know what night, how you want to, so, but these are basically 2021 numbers, and we have gotten very busy compared to this, but these are each state, how they go up and down, and how we use these numbers to staff shifts. On the left side here is 7 days of the week. This is the weekly report, and this is just basically a running number of every week, how they go. Right now we're at 280, I believe, 280 consults a week. But these are all the 7 days of the week. We have realized Tuesday is our busiest day by far. So I don't know but this is interesting tidbits about which is the busiest or not, but Tuesday has been our busiest day. So operationalizing like a big network, physician network, provider network, you really need a good credentialing and licensing team in your group. So when we started out, we just had a coordinator who used to do licensing and credentialing for all the physicians. In our case, we had a few licenses, but if it's just one license and like 6 or 7 hospitals, a very efficient coordinator can probably handle that part of their other existing job, and it takes around 1.5 years to get onboarded with us, because it just takes 8 licenses and 100 hospitals, right? So it just takes a long time. But smaller, when we started out, it was very easy. When we licensed ourselves, like in 2 months, we were ready to start telemedicine. So again, these are the different layers of physician experience which we enjoy. We, of course, have a unified PAC system where all the external and internal PACs are uploaded to this, so that we don't have to log into Epic. We do log into Epic sometimes to see review the CTs and the CT angiograms. We have a portal just to make us more efficient. Of course, we have Epic for the most part. We have case reviews. We have a map. Since we're in 8 states, sometimes it's hard to make sense of a geography where these patients. And the portal also tells us how to hand off this patient to the local hub, how to communicate with the local neurologist or the ICU intensivist or hospitalist. So we have all the information in the portal. Yeah. So this is what our portal looks like. When I log into the portal, it has on the left side is all the patients. So these are all closed cases. That means I've completed the survey and documentation. And as soon as I get paid, this is going to be blue, and this will tell me that, hey, any open cases, any unassigned cases, these are unassigned, these are my cases. And if you look here on the left side, there is all patient information collected by the access center. And on the right side, there is how do we operate in that site. There is information about handoffs. How do we give handoffs to the local team? And also there are some power buttons here where I can say, hey, request backup. So as soon as I click on that button, this case is going to be unassigned from my side, and it's going to be paged. The next provider is going to be paged. Let's say you're handling 2 cases and suddenly you feel that one case you really need to have a lot of effort. You can just say request backup. It's just going to get you off that case. And then you have images not available. That means if you click on this button, the access center agent is going to call the radiology department and say, hey, images are not available. Dr. Bhatt needs to review the CTA. Can you push the images again? Again, these issues are not relevant if all the sites are in the same Epic system. That's all natural. But some of our sites are like external. So we want to make sure that they follow processes on their end. Card is not ready means the card's on the hallway, not with the patient. So it's very important for the card to be with the patient, especially when you're deciding for TNK or TPA. And nurse is not at the bedside because we require a nurse to be at the bedside to evaluate the patients. So these are the power buttons where you can always call the agent on the top and ask for more help if you want. This is what our survey looks like. We collect all this data and we give the feedback towards the end of the session, and we note whether we documented the patient in Epic or not. So it's 100% documentation, so everybody should document, except for the fact that if the consult was canceled, then we don't need to document. And it's a very quick survey, like 15, 20 minutes. This is how we collect the data. We develop dashboards based on this data, and it helps us maintain relationships with all these sites. This is a physician feedback survey. If you look here in the portal at the end, I can give feedback too. And average feedback is pretty good. And typically, if I click 5 out of 5 stars, I don't need to write anything. If I say 4 out of 5, it will force me to write something at the bottom here. It's all subjective. This is the happy map where we can zoom in, try to figure out how to transfer these cases. We're not responsible for transfers, but sometimes handoffs we have to give. All this information is also in the portal itself, so that we can we are able to efficiently work when we are doing the shift. So regarding billing, so this is a slide prepared by our billing manager. So I know each state is different. The billing manager, so we have the FAST Act, which was passed, I think, 2 years ago, which the Medicare and now most of the insurance companies cover stroke billing. Whether it's the acute stroke, whether it's a follow-up, it does cover the billing. And it reimburses at the same level if you would do inpatient care. We have other insurance companies which also reimburse us, but Medicare is the primary one here, as you see here. So these are Medicare reimbursements for these codes here. And we also have the critical care codes, 508, 509. They have higher reimbursement. And of course, acute stroke would qualify for that. So I think it's like 250 or something like that for these two. And these are the different codes we used. These are all Medicare, Medicaid codes, but you can do private codes with telehealth modifiers. But now over the years, I mean, more and more payers are paying for, especially neurology and stroke. So I know I want to just briefly touch base with Tele-EEG, where so we have a separate group of epileptologists who review EEG. If some of the hospitals don't have docs and they just want to have a stat Tele-EEG service, and some have continuous monitoring, and they try to use, of course, the 32-channel EEG, but sometimes these are small sites, and we have a TeleNeurology program at these sites, so they do Cerebell to triage patients for if there is an acute status or something like that. I know it's not accurate, but all the time, but they do find helpful. Most of our places have 32-channel EEG, and they have an acute and a 24 like a remote monitoring capability. So this is an important piece for a teleneurology service if they want to keep patients at the site, because the primary goal of EEG is that, do you really want to transfer this case just for the EEG? Happens all the time in our institution. So yeah, hybrid care, this is the map of Alaska. So Alaska is obviously the largest state in the country. They have 13 neurologists right now in the whole state. And out of the 13, 4 are part of Providence in Anchorage, Providence Alaska Medical Center. And in the next few years, at least half of the 13 neurologists are going to retire. So Alaska is a great example where they in the community, the neurologists are getting hammered by these outpatients. They're trying to service, they're trying to do as much as rounding as possible during the daytime, but we're supporting Providence Anchorage for like the acute services, for acute teleneurology and acute stroke. So I do feel that some of these states or geographies will require some neurology presence, but the only reason they're able to retain their docs is because they have 24/7 tele coverage. Otherwise, the docs would have just left or stopped practicing altogether. So given the shortage of neurologists in our country, regardless of where you live, I think it's important to recognize that even if we're not doing 24/7 telemedicine, telestroke, teleneurology, the groups will eventually adopt teleneurology in some fashion, whether it's just nights or just acutes. And it all depends on the type of group, how many docs you have, and what stage of their careers they are, and how many nights you want to do. All these conversations we have all the time with our docs. Yeah, so I think this is it. I mean, like there are other slides, but I do feel that I've covered pretty much everything, and I just want to make sure that I have some time for questions as well. Typically, so we have around 101 hospitals, 102 hospitals, I think. More than half of them are outside partners. So agreements would be typically a per click rate and some sort of a subscription, little bit of subscription rate to cover the overheads, right? So we try to do that at least for the decent sized hospitals. If it's a critical access hospital, very tiny hospital, they're often subsidized by the regions because they end up just requiring a lot of higher level of care at these regions. But if there is a decent sized hospital, they are usually per click with some subscription fee to cover the costs as much as possible. We also do the billing. Obviously, billing is not going to cover all the physician and provider costs, but we try to make the business as efficient as possible. Say, hey, some billing, some subscription, some per click, and just make it work.
I saw you had feedback for the doctors and the nurses after the consultation. Do you have feedback for the patients or the families as far as their satisfaction with the service?
We tried to implement that. We were not very successful. I think the survey was focused on patients having an acute stroke, and just hard to get an immediate feedback from them because they're already distressed by so much going on, and the compliance was low, and we just had very extreme responses. So we felt that it may work maybe in an outpatient setting, but in acute care, I think may not be the right approach.
Oh, I said that he had surveys for the nurses and the doctors involved in the telestroke consultations, but did they have any surveys from the patients who experienced telestroke? And it sounds like in the acute setting, it's not possible.
Okay. Great.
I don't think, is it?
Let's try it.
Okay. I didn't see any APPs that you guys work with. You guys see any other groups that typically utilize APPs with teleneurology, and how does that work?
Yeah, so we have like 12 comprehensive stroke centers, and we have a very solid group of APPs who work in person. But we have not used APPs for teleneurology, but we are planning to hire a few. And the way we want to do them is to have them as for the rounding service. Like acute service, physicians will respond. I would say 30% of cases are going to be acute, they'll take care of it. But some of these cases will just require consultation like few hours later or the next day. And I think it can be very efficiently done with APPs. And of course, if there's a complex case, they can always discuss with the doc. And that's how we do it sometimes in some of these comprehensive centers too. Some of our APPs respond to code strokes. It's very variable. But we don't have a rounding service as of yet, but some of the sites are requesting rounding services. And we said, we have a great team of APPs, and we're going to probably partner with them to execute that.
Dr. Bhatt, thank you. Can you give us just your vision on the future? I mean, what's going to be in the future, you think, with all this tele thing and centers around the nation?
So specifically talking about teleneurology, is that correct? Okay. So again, less neurologists. I would say the future is going to be hybrid care, where what we do, let's say, for example, forget the telestroke piece. We have two comprehensive stroke centers, which I'm primarily employed with in Portland. During the daytime, we do in-person stroke, and during the nighttime, we take call from home. Like we do stroke, we do teleneuro, we use the robots, because we can't be two places at once. And also it's more efficient from home. So that would be at a local level. But at a national level, what's happening is there are these big companies like telespecialists, specialists on call. There are a couple of other companies who have developed these platforms where they insert docs and they've scaled teleneurology and telestroke. And I do feel that eventually it's going to be a few platforms, like 4 or 5, who are going to be servicing the different regions. Not necessarily the physicians, but the technology platforms, because how they, like, great example is like the dialysis companies. Like there are only 2 dialysis companies. Perfusion software, only 2 or 3 are there. So eventually it's going to be like that, where the docs will just gravitate to these platforms and say, hey, I will work for Wrangler because they have this platform. It's more efficient. And these are not EMRs, but they just make the docs very efficient. You can service more than one hospital. And why do you want to service more than one hospital? Because you just don't have enough neurologists. And if you end up hiring neurologists at each and every site, it's just going to be super expensive. So I do feel that there is going to be hybrid care, and there is going to be, most of it's going to be for profit, but a lot of nonprofits will have opportunity to do teleneurology as well. Yeah, and it can be a small program. There are a lot of successful small programs, like 6, 7 hospitals. They don't want to grow, but they want to take care of their own system.
How about patients once they leave the hospital, and how do you know about their outcomes, and do you follow them as an outpatient? And how is all we do? This is a model that's more designed for hospital care and acute care. How do you monitor the outcomes later on to be able to determine what the outcomes are?
Yes, it's so the outcomes also depend on the ability to collect the data. So one of the challenges we've had is that a lot of these hospitals are like rural hospitals, families like scattered around the country, 8 states. We do have Get With The Guidelines database for most of the hospitals. I would say 70% of the hospitals, and they have outcomes for length of stay and hemorrhage, and sometimes functional status at 3 months. We try to collect as much as possible, but it's extremely difficult to have like a uniform functional data at 3 months for all these patients, because they're just so scattered around, and most of them just don't follow up, right? They just follow up with their PCPs. And that's why that's a challenge. And I agree with you that there is no way to measure that. We we do have some smaller regional programs where they have telestroke clinics, where we have a small iPad with camera in one of the outlying clinics, and our stroke docs, they just evaluate the patient remotely, because most of these patients, we already know a patient has a stroke. The diagnosis is not in doubt. It's more of, okay, are they on the right medications? Do they need additional imaging, additional ancillary testing? That can be done, remotely, and they don't have to drive in like 60 miles, 70 miles, and especially with the gas prices now. I mean, it's very hard. So that's what we try to do, where these clinics, we cluster them based on how busy they are, and the docs are just see them on Zoom with Epic. We've done that.
So I think I one question as to how what the future holds is there going to be more integration between outpatient, not just teleneurology, but telemedicine services and inpatient, so these things can work in tandem. Because I think that there's companies like Teladoc, for example, and they might have their own neurologist, but they're outpatient only. It seems like both systems, an outpatient system and an inpatient system, are developing from different places. How they're going to manage, I guess, is a question for.
Yes, it's very hard. So what Teladoc is doing is they are creating a technological silo. They are creating their own platform. They're going to have their own neurologists. They're like kind of like an EMR light, and they take care of their patients. But the type of patients are going to be like different, right? So what they're targeting is they are targeting healthy patients who just needs follow-up, like headache or like a seizure, right? So not very vulnerable patients. These are all functional patients who can pay cash, who can use iPads, who can use phones, direct to consumer type of model. What, as a health system, like I work for Providence, most of my patients are like, they barely can move after a stroke for a few months, right? And they are more vulnerable. They require some family member to do a remote visit. But I agree with you that they are targeting a unique clientele who can pay cash or has insurance. They have their own online system. But I do feel that long term, if they don't integrate with a health system or health systems, that model is not going to work out, because it's a trust issue. Neurologists, you really need to develop that trust. Yes, you can have an online doctor for headache, maybe like some prescriptions or follow up, but when you have a serious medical condition, they really want to see in person. And maybe you can follow up that patient the second visit or the third visit, just hybrid care. But the trust is the key. And I don't think so they will be able to get trust with this online model. Primary care is different. What Amazon is doing is that can disrupt a lot of things, because they are focusing on primary care only. And prescription, they already have their own company, right? So they're trying to reduce costs. But again, they're not targeting sicker patients, right? They're only targeting healthier patients who work for Amazon.
We also have proximity, for example, which is how I do my outpatient virtual visits, which is a separate system than what you use for Telestroke.
And which is fine to have a different technology to use. But may I ask, you're talking about what specialty you're in?
I do neurology and sleep medicine.
Yeah, sleep.
A lot of my sleep medicine follow-ups are very appropriate for outpatient, requires minimal examination. And you always have the option of writing a disclaimer and saying, this patient, I need to see you in person because I can't evaluate this or that. I can't see your fundus to see if you have edema or whatever you need to come in. But we are in I see more and more pressures in an area like this. There's a lot of people that just don't want to drive or they need outpatient access and as well as inpatient access. So I'm kind of foreseeing 20 years there'll be these networks where inpatient and outpatient virtual medicine will be better integrated. And some winners or losers are going to be weeded out.
I agree. It's the integration is key, and also reimbursement, right? So we also have challenges with reimbursement. I know we are in a COVID emergency phase right now, and I believe they have extended their reimbursement for inpatient services, but they extend it every few months. There's no law for them to do it. So I think reimbursement is there. Technology, as you said, is going to mature over time and will be integrated. But then how many portals can docs handle, right? You don't want like 15 portals. So it's going to be one or two, the winners and losers, as you said, like it's not going to be a lot. There will be a few which will be integrated, user-friendly, the docs will use.
I just have a question surrounding the medical record documentation at all of these hospitals. Is that something that you all have from the Providence Telehealth that you send to these facilities, or are you all integrated with every medical record system that each hospital has?
Very good question. But again, for all the Epic hospitals, we directly document in their system.
In Epic, okay.
Yeah, because it's I know there's a separate login for each system, but I mean we do log in and we document. If it's a non-Epic, what we do is we document in our portal, and we fax the note to the site.
And that portal is through Teladoc?
No, it's
Okay.
our own portal we built on Salesforce.
Okay.
It's HIPAA compliant, and it has all the data. And we also copy and paste the note from the portal in our Providence Epic in case something happens to the portal in the future, right? So we have that note in our Epic just as a ghost encounter. Hey, this patient was seen, patient's in a different hospital, but this is where the note is going to live. So let's say, for example, you are doing telestroke for a non-Irregular hospital, you can still document in your Epic and fax the note from your Epic to that site. You can do that. You don't need a portal for that. But that's one way to look at that. Yeah, thank you. Okay. Okay, thank you, Dr. Sir.
Thank you. It's great.